completed an internal medicine residency and cardiology fellowship down in San Francisco at the Letterman Army Medical Center. He is currently at Ochsner Clinic and is the Chief of Medical Services for Ochsner Medical Center and the System Chairman for Cardiovascular Disease at the Ochsner Health System and the Medical Director of the Ochsner Heart and Vascular Institute. He is also a past president of the Society of Coronary Angiography and Intervention, which is the main society for interventional cardiologists. And he is also an editor for the editor-in-chief, for Catheterization and Cardiovascular Intervention, which is interventional cardiologists' main journal. And he has authored more than 250 manuscripts, 5 books, and 43 book chapters. So we'd like to welcome our keynote lecturer, Dr. White, who's going to be speaking on the optimal management of peripheral arterial disease.
Thank you very much. I appreciate it. Oh, I'm good, I think. Well, quite a crowd. I'm really very, very impressed with the ability of Dr. Khan to gather this group together. I realize this program builds year to year. I was out here about 3 years ago, and it's just nice to see the enthusiasm that there is for education and for knowledge. I'm going to educate you a little bit today, but I'm going to challenge you a little bit today. And I think that we're in a period of time in healthcare when we are faced with challenges. And so we just need to understand what they are. I have tremendous confidence in our ability to meet these challenges. There's no better practice of medicine in the world than we have in the United States. But it's important that we understand the why and that we understand what needs to be done before we can get there. And I think there's still a little bit of confusion. And so we're going to talk about PAD, and then we're going to talk about how PAD impacts our practices and what we can do to prepare for the future. And so the title of this talk is The Optimal Management of Peripheral Arterial Disease. Now, unfortunately, I really don't have any financial conflicts. And so as you visit the vendors, if there's anybody out there who would like to pay me to say something, I'm more than willing to do that. I just don't understand why they don't take advantage of it. It's critically important when you manage patients with atherosclerosis that you understand that atherosclerosis is a systemic illness. We tend to make silos. We have cardiology and we have vascular surgery or vascular medicine. We have interventional radiology. We have neuroradiology. We sort of break these diseases down by subspecialties, but the diseases do not obey those rules. And so it's critically important to understand that when you're seeing a patient who has angina, that you feel their pulses and that you take their blood pressure in both arms and that you listen for bruits in the neck and that you take their shoes and socks off every visit. How hard is that? And yet I find that in my institution, one of the hardest things to do is get blood pressures in both arms and shoes and socks off for every patient that I see in the clinic. That simple thing really helps uncover a lot of unrecognized problems in our diabetic patients, our hypertensive patients, who we know we're seeing for coronary disease. But there are other issues going on. So do not forget that this patient has many other facets to them. They just may not be the reason they came to the clinic that day. The other thing I want to emphasize today is the severity of peripheral arterial disease and the burden of this disease. By the time patients are symptomatic from peripheral arterial disease, they have tremendous burdens of disease. This burden of disease makes itself known in other ways, heart attacks and strokes. But statistically, when you see a patient with peripheral arterial disease, 1 in 4 of those patients won't be there in 5 years. There are very few malignancies who have that rate of mortality. This is a mortal disease. And when we see patients with peripheral vascular disease, who we understand have lots of vascular disease in order to be symptomatic from that, it's really important that we motivate them to some of the best medical practices that I'm going to talk to you about today, the guideline-directed medical therapy. It's not optional for them to quit smoking. It's not optional for them not to take a statin because their left elbow gets sore when they play tennis. You have to push this drug, right? It seems silly that you do, but if you don't get their LDL down, these people aren't going to be there soon. So it's important that we promote to them the wellness that we need. Today we're going to talk about two elements of peripheral arterial disease. We're going to talk about chronic stable limb ischemia, which is basically claudication. And we're going to talk about critical limb ischemia, which is obviously a dramatic manifestation of this disease that results in mortality and limb loss. I need to put in perspective for you the average patient who comes to see us with peripheral arterial disease. Fully half of those patients will be asymptomatic. And that's okay, because they still need to be treated. The difference between primary prevention and secondary prevention is your ability to perform an ankle brachial index. And I was just talking with Dr. Kahn yesterday about whether or not we get reimbursed for certain categories of patients with ABIs. But ABI is a very inexpensive, low-risk procedure to perform. We're going to talk about it in a minute. But if you perform an ABI on a patient who's in your practice for any other atherosclerotic reason, and that ankle brachial index is 0.9 or below, that patient has PAD. That's a diagnosis of PAD, regardless of their symptoms. And you then can treat that patient with secondary prevention, which is a much more aggressive form of therapy than for primary prevention. The next thing is to understand atypical claudication. So oftentimes my fellows will see patients and they'll come back and I'll say, does he have claudication? And the fellow will say, nope, doesn't have claudication. I say, well, does he have any problems walking? And the fellow says, well, I didn't ask. And I say, well, that's why you're a fellow. So you go back into the room and you talk to the patient and you ask the patient, do you have claudication? They don't know claudication, which is what the fellow just did. So then you say, do you have any trouble walking? And the guy says, well, yeah, I don't walk as well as I used to. I can't get to the Superdome to see the Saints, that kind of thing. And then you ask him why. You say, do your muscles cramp when you walk? And he says, no, my legs get tired. My legs get tired. My legs give out. There are a ton of ways to describe their inability to exercise that do not qualify for typical claudication. And I think that's one of the knowledge bases that we need to have, and that is let them describe to you their limitation any way they like, but measure that ABI, and that atypical symptom becomes an atypical claudication symptom, and you can use that to measure when those patients are needing and will benefit from revascularization. So I'm going to talk just for a minute about ankle brachial index. Everybody in this room this morning should be able to leave with an understanding of how to perform an ankle brachial index. It's a critical procedure for patients with peripheral arterial disease. So what we take is blood pressures in both arms, and then we use a Doppler to take blood pressures in the feet, both the dorsalis pedis and the posterior tibial on both sides. And the counterintuitive thing, and there's just no explaining this nonsense, but we are interested in the highest blood pressures. Now, if you were hunting down a blocked artery, why are you looking for the highest pressure, right? You should be looking for the lowest pressure because the artery with the most blockage is going to have the lowest blood pressure. But whoever figured this crap out just decided to make it a little bit difficult for us and said that the code is we're going to only use high blood pressure, the highest. So you take both arm blood pressures and you take the highest of those, that's your numerator, and then you take on each leg, you take the dorsalis pedis posterior tibial, and you take the highest one of those, and that becomes your denominator, and that is what should be greater than 1 or greater, and if it's 0.9 or less, that's what this is. So I've got a sample thought experiment for us this morning. Here's a patient who's got right arm blood pressure is 150 over 80 and left of 120 over 98, and then you can see his dorsalis pedis on the right is 100 over 50, 60 over 40, and the posterior tibial, and on the left it's 75 over 50. So the question is, what's this patient's ankle brachial index? If you'd have known I was going to ask you to do math this morning, you wouldn't have come probably, right? So basically what you want to do is you want to look for the highest arm pressure, which is the 150. And then on the right leg, you want to look for the highest pressure, which is the dorsalis pedis, which is 100. And on the left, you see the posterior tibial 75. So it's 0.66 and 0.50. And that's the way we do it. It's convention. You don't have to reason it out. It's just the way it works. Okay? We can talk about this if that confused you at all. When we ask questions, we can go through this again. So I talked to you about asymptomatic patients. Patients who have PAD by an abnormal ABI, but who are asymptomatic, will benefit from very aggressive secondary prevention. And that's guideline-directed medical therapy, which includes smoking cessation, and I mean serious smoking cessation. I mean guilt-provoking smoking cessation. If you don't make people feel guilty, offer to commit seppuku on their way out of the office, you haven't done your job, right? You have to look at them, shake their head. You're still smoking, you idiot, you can't smoke. Don't come back and see me if you're smoking next time. I mean, it has to be serious because these folks have heard it all. There isn't a soul who smokes who doesn't understand they shouldn't. They've already overcome a lot of those barriers. So it doesn't do us any good to acknowledge it. You can't pat them on the back and say, yeah, I know it's tough. Let's light up together at lunch. That doesn't work. Now, for patients who are symptomatic from claudication, we're going to talk about treatments. And the fundamental treatment, again, continues to be guideline-directed medical therapy. We'll talk about that, but it's statins, it's blood pressure control, ACE inhibitors. But also, we want to exercise these patients. And we want to exercise them no matter what we do. Exercise is always going to be a cornerstone of the best therapy for these folks. So here's what happens when patients adhere to guidelines. So on the top left is major adverse cardiovascular events, and the red line are the folks who are adherent or have less than 4 guideline therapies, and the blue line is patients who are adherent to 4 guideline therapies. And you can see the big divergence of the event rate. I mean, if you are on guideline-directed medical therapy, you do a lot better than if you're not. And male is major adverse limb events. And if you look at that bottom curve, you can see that the blue line is a lot better than the red line. So do not underestimate the power of best medical therapies, guideline-directed medical therapies for peripheral arterial disease. Cornerstone of what we do, we build on this with revascularization and other things. What about exercise and cilostazol? There's only one drug that you have to worry about for claudication, and that's cilostazol. Nothing else works. There's other things out there, they don't work. Don't do them, they're expensive. Don't discourage your patients from going to the GNC store and buying stuff off the wall. It's just a waste of money. If they insist on doing that, tell them you need 10% of it so that you can at least get a benefit. If they're going to throw their money away, you should share. I find that when I say that to them, it becomes meaningful because they look at me kind of like, are you sure? Are you serious? And I'm thinking, yeah, you're going to throw your money away, leave some here. It's stupid to go to GNC and buy these things. But cilostazol works. It's the only drug, and it's been repeatedly proven with exercise to improve walking distance. Remember that you can't use it with heart failure. So that means an abnormal ejection fraction or any other manifestation of heart failure that you think the patient's had, that becomes a contraindication to cilostazol. It may take a couple of months to achieve peak effect, so don't be impatient. In fact, set that expectation for your patient that this walking benefit may not appear for 2 or 3 months. And finally, there's GI intolerance commonly with this drug, particularly on starting it. So with the elderly folks, the first thing I say to them is, are you having any bowel problems? Because almost all of them are constipated. And I say, this is a twofer. It will go away. The effect on their GI tract will wane over the first week or so. So you have to encourage them to sort of get over that hump because many of them will want to stop cilostazol. And before I will stop it, I also reduce the dose by half. I sometimes go to every other day dose. I'll do anything that I need to do to get cilostazol into their body and then walk them up to the therapeutic dose, even if they can't tolerate the dose right off the bat. Again, the indications for revascularization, and so far we're talking about whether we talk about angioplasty or surgery, are lifestyle or occupational limiting symptoms. There are people who are working with their legs, people who deliver things, people who mailmen, people who work in plants that have to walk. And when they claudicate, they can't do their job. And that elevates the urgency for their revascularization. You have other folks who are not having their employment embarrassed. We can be a little more patient with them. Their PAD's not going away. They're going to be there tomorrow. We don't have to rush to get them on the cath table tomorrow. We can be patient. But people who have employment limitations deserve to be accelerated through this process. I prefer to have patients fail cilostazol in some exercise program before we actually intervene on them, and typically that's okay. And then you want an anatomically suitable lesion for angioplasty. And then finally, considering the risk and benefit. So if somebody has claudication at 2 blocks, they can do their life, they can grocery shop, they can do what they need to do, but they want to do more and they're limited. But their creatinine is 1.7 or 1.8. Why do I want to do that? right? I don't want to expose that kidney to contrast until they are much, much more limited. So you make that risk-benefit judgment all the time when you see patients. It's not that you do the same thing for every person. Remember, with claudicants, the goal is to improve function, not limb salvage. Very few claudicants will lose their limb. You can reassure them about that. It's in the low single digits. Very few claudicants will progress to limb salvage. So you can tell them it's a long race and we're going to be in this for a long time, and whatever we do to them is something we have to be able to sustain. It really doesn't do any good to have claudication go away for 3 months and then come back, because then I have to do something else again. So I'm really looking for a sustained improvement. And you'll see today when we talk about some of the therapies, I'm going to emphasize to you the length of benefit, the length of improvement that we get from these therapies. Not that these therapies are 99% effective today and tomorrow, but what will they be like a year or 2 or 5 down the road? Again, crucial to the success of treatment of claudicators is function. We're not talking about critical limb ischemia. We'll get to that in a minute. Critical limb ischemia, I'm happy for a couple of weeks of blood flow to heal an ulcer. That's a different story. But for claudicants, I really need durable therapy. I need exercise therapy, and I need guideline-directed medical therapy. So here's the debate. Are stents better than exercise? I don't know where this debate comes from. It's absolutely nonsense. I don't want to debate this. I want to prove to you that both work better than either one alone. So I want a patient, and that's what the ERASE trial was. This is not PTA in patients having sex, by the way. Actually, it's not a bad thought. But this is supervised exercise, right? So PTA and supervised exercise together, the blue bar, is better than the orange bar. And so, again, why do you have to pick? Why do you have to separate? Exercise is going to be good for everything about them. And so you want to encourage a habit of exercise, and then you use revascularization as you need to, and that's how you optimize the benefit. There's no reason for a debate. And the good news is, coming down the pike, is coverage. CMS is going to begin to pay for supervised exercise, or what we call rehab. So we have peripheral arterial disease rehab, just like we have cardiac rehab. Right now, you may know that you don't get paid for that, so you don't see very much rehab programs for PAD. But when Medicare will pay for this, just like they pay for cardiac rehab, that will enable a lot of patients to do this. The other thing that's coming probably next year are bundled payments for much of cardiovascular disease. And rehabilitation, cardiac rehab, and exercise are a big part of the bundles. They're going to pay for that. So if you have a nice rehabilitation program going, you need to today start to plan to expand that to be able to handle the peripheral arterial disease that will be coming down the pike by the end of the year, I hope. What about innovative solutions to this problem? Well, iliac stents are a place to start. You know, I've been doing this almost as long as Dr. Paul Maz has been thinking about this since it was a gleam in his eye for iliac stenting. And frankly, I used to choose between balloon expandable stents and self-expanding stents based upon performance criteria, like precision or the need to accommodate for different size vessels with self-expanding stents. But actually, a study's now been done that compared these patients who could have either balloon expandable or self-expanding stents. And it turns out that self-expanding stents had better outcomes than balloon expandable stents. Go figure. So these days, if a patient can have either device, and you're in the cath lab trying to figure out what to pick off the shelf, you're better off picking a self-expanding stent than a balloon expandable stent, if the patient can have either device. What about drug-eluting stents? Drug-eluting stents have been a huge battle for us in the periphery. There's been lots of failures. It's been nowhere near as easy as coronary drug-eluting stents. Finally, there's been a breakthrough device, a self-expanding drug-eluting stent for the femoral artery, and this is the 2-year patency data for the Zilver device. And you can see, again, we talk about durability of this treatment, and over 2 years you can see 75% of the drug-coated stents were patent versus angioplasty, which only had 26%. Now you say, well, we just really don't do angioplasty anymore, we do other things. And so this is 5-year data now on drug-coated stents, and on the left-hand side, you can see that compared to standard of care, which is typically balloon plus bailout stenting, the patency rate was 66 versus 43, so that's pretty good in 5 years. And if you look on the right side, it's provisional drug-eluting stents versus provisional bare metal stents, and you can see again the amplification of that durability. So it's pretty easy to start thinking about strategies of these patients when you say, well, what am I going to do if this happens, if I get a dissection, or what device should I start with? And you're cost conscious and you want to be careful, but it's hard to give up this amount of delta for patency without recognizing the benefits of some of these tools. Drug-coated balloons, these are going to save us. They're really good in big arteries. We'll talk about some of their weaknesses in smaller arteries. But this is one-year data for a drug-coated balloon, and you see that the patency rate here is 97% versus 80% in the conventional treatment. And if you look at this meta-analysis, we're talking about hard endpoints here. At the bottom, we talk about the difference in restenosis and target lesion revascularization. And if we look at 5-year data, again, when we start talking about durable therapies, this is what I think is meaningful. You see that these benefits last 5 years after we treat these patients. So for claudicants, there's a lot of bang for our buck in this kind of treatment. There's a dark side to drug-coated balloons. It's not all happiness. It turns out, and this is data from 3 trials, but it turns out that the class effect might not be there. We've gotten kind of lazy in cardiology because there are a bunch of companies and they make drug-coated stents and other things. And we tend to not differentiate very much among the companies or the devices or the formulations. We sort of say they're all about the same, they get about the same effect. That may not be true for drug-coated balloons. There may be differences by manufacturer. There may be differences in formulation. There may be difference in a thing called the excipient, which is what binds the drug to the balloon. These are all things that affect performance. And it looks like not all drug-coated balloons are created equally. And so you're going to need to educate yourself and think a little bit about what device you're pulling off the shelf. This is drug-coated balloons below the knee. It turns out that drug-coated balloons don't work in the coronaries, and they don't look like they work in the tibials. And that may have to do with size, recoil, intimal hyperplasia. In a big artery, like a 6 or 7 millimeter femoral artery, drug-coated balloon has plenty of room to work. But in a 2.5 millimeter artery, there's not much margin. So I'm going to show you how much better drug-coated stents are in the tibial arteries than are the drug-coated balloons. So drug-coated balloons for the lower below the knee is probably not a great choice. This is the IMPACT DEEP trial, which shows there was a safety signal. There actually was a questionable amount of more amputation in the drug-coated balloon group. Rita Redberg is a California cardiologist, right? She's one of yours. You have to take responsibility for her. I blame you guys on that all the time. Rita is the editor of a journal, a medicine journal, and she hates us. She hates us. She hates me. And she hates me because she thinks I do shamoplasty. She thinks I take money and don't give anything back to the patients. And so she makes cartoons like I'm showing you here and puts it on a website and sort of damns us. The thing that we do that battles these kind of skeptics who think that we're not exactly committed to what our patients need are appropriate use documents, guideline-based, evidence-based practice, and best practices. I've shown you here there are 4 documents that my society, SCI, as Omar mentioned. SCII has put out appropriate use documents for peripheral arterial disease. I'll tell you that next week we will publish an update to these documents, which are published in 2014, so there'll be news, you'll hear about this, but the updated document to take into account the drug-coated balloons and drug-eluting stent data that wasn't quite mature in 2014. But if we are evidence-based practice and we are guideline-based, we can hold our heads high in how we practice our interventional medicine. There are some things we do that don't make a lot of sense. We first tried to heat things up with a hot tip laser, and that didn't work so good. Some of us may have participated in those trials. Then we said, well, if heating doesn't work, let's freeze the shit out. And that made some guys a lot of money, but unfortunately it doesn't work. And so we want to make sure that we're not behind the times about where our efficacy is. So cryoplasty has yet to show any sustained benefit. Covered stents in the femoral arteries don't work. Covered stents in the femoral arteries, just by and large, are not a great idea for lowering or increasing patency over the long run. There may be a time when you want to use them. It's not that they can't be used, but you don't want covered stents to be your go-to device for femoral disease. The cutting balloon, this is a great one. The cutting balloon has a great utility, and that is for undilatable lesions, the cutting balloon can be really helpful. Razor blades on a balloon, right? But there are times when it can save your bacon. Nothing will expand a lesion. A cutting balloon will work. So there's no question about that. But a cutting balloon for instant restenosis, a cutting balloon for a calcified lesion that can be balloon expandable, there's no role for this. And the funny part of this is this bar graph that shows the inefficiency of this device. This is on the company's website. The company says, my device doesn't work. Will you buy it? And then the laser. The laser's my favorite. I was a laser jock from way back. I was into, when I was at Letterman, Letterman had a huge laser operation for other reasons. They were trying to shoot helicopter pilots now with lasers. Anyway, I convinced them that if they would fund me, I would tell them about laser tissue interactions so they could protect their helicopter pilots' eyes. I had no interest in ophthalmology. We were looking at coronary arteries. Turned out not to work very well. But one thing the laser does do and has done for more than 20 years is these are big boxes. They're heavy, and they will keep a door open come hell or high water. I mean, if you are trying to wedge open a cath lab door, I guarantee that an excimer laser will be the device of choice for that. Just don't turn it on in the body. Unless, of course, there is one randomized trial that has demonstrated benefit for the laser. I'll show you here that in the EXCITE in-stent restenosis trial for femoral artery in-stent restenosis, there actually was a significant benefit for laser therapy. So as an adjunctive therapy for patients with particularly diffuse in-stent restenosis, not a bad idea to try the laser. So one thing that works. Atherectomy in its multiple manifestations, I don't care whether it rotates, spins, stands on its head, atherectomy doesn't work. And the reason atherectomy doesn't work, I laugh at this, what John Ochsner, the son of the founder of my clinic, is a surgeon. He's a heart surgeon. And back in the 80s, he would come to me and I would pull meat out of the femoral artery with these slicer, dicer devices. And I'd have a pile of atheroma there sitting on the side. He'd walk in and he'd say, "What you doing, Mighty Mouse?" He used to call me Mighty Mouse. And I'd say, "John, I'm putting you out of business. I'm putting you out of business. We don't need surgeons anymore. I can do this with my catheter." And he laughed and he said, "You know, do you not read the literature? We did this in 1968. We proved that endarterectomy doesn't work." And that's true. The surgeons have really done elegant studies looking at endarterectomies, which are so much better than any atherectomy we can perform. And they just don't work in the femoral artery. Work beautiful in the carotids, beautiful, not in the femoral artery. So we just keep looking at procedures and how they look the day we're done. We don't look at how they look in 6 months or a year, because atherectomy at this point has absolutely no benefit, does not add to anything we do clinically. I'm going to switch gears and talk a little bit about critical limb ischemia. I want to make sure everyone here understands that amputation is not a great option for patients with critical limb ischemia. It's not a never event. It's not never, and we'll talk about patients in whom amputation might actually be the best treatment. But most of the time, we're taking off way too many legs in this country for patients with critical limb ischemia. The primary purpose is for limb salvage. That's what we do. And again, long patency is great, but for these patients, a couple of weeks can be the difference between losing a foot and keeping the foot attached. But there are factors, such as being bedbound or nursing home bound, being not likely to ambulate because of dementia, that sometimes mean that an amputation might be a quicker, better way to deal with that patient than to put them through a bunch of repeated peripheral vascular procedures. So there are patients in whom amputation is the best solution. It's just not the majority. And it ought to be a discussion between the team. Multidisciplinary folks ought to have that conversation before somebody asks an orthopedic surgeon to whack off a leg. Again, I've talked to you about the mortality in general for PAD, but you can see here in CLI, this rate of mortality is greater than almost all cancers. There are a few cancers that are more lethal than critical limb ischemia. So we need to pay attention to the blocking and tackling of these patients, and this gets back to guideline-directed medical therapy. So patient survival is impacted by anti-atherosclerotic medicines, statins. Your patients have to take statins. For some reason, and this is probably just life, they love to tell me they can't take statins. I bet you 9 out of 10 of the patients who walk into my office want to tell me why they can't take a statin. And I'm saying, why don't you just load a gun and put it to your head? I mean, don't tell me you can't take statins. You find a way to take a statin. You have to take this drug. I've got 7 of them you can pick from. They don't like to take statins. We have to be firm about this. You cannot fatigue. You know, Vince Lombardi was famous for saying, "Fatigue makes cowards of us all." You get tired, 8th or 9th, 10th patient of the day telling you that statin makes their elbow sore, and you're thinking, "Man, I can't do this anymore." You need to just take a break and go back in and say, "You got to take this statin." It's critical to how these patients do. Antiplatelet therapy, typically aspirin alone. Patients, as they get older with this vascular disease, have a lot of problems from bleeding with aspirin. So there's a lot of GI bleeding. There's a lot of problems. So if people are having difficulty with aspirin, switch them to another antiplatelet. Platol is a perfect example. Cilostazol, single dose, not dual antiplatelet therapy, but single dose if they can't take aspirin. That's a perfectly acceptable alternative. and in the guidelines, it's an acceptable substitute for aspirin. And then ACE inhibitors. ACE inhibitors, again, like statins, should be in the water. I mean, ACE inhibitors are so good for our endothelial cells. My endothelial cells just go, oh, every time I take them. I mean, there is nothing better than a lisinopril in the morning. It's really, this will do it for you. So look for every opportunity to wedge an ACE inhibitor, a generic ACE inhibitor, into your patient's day. We're going to be talking about claudication or critical limb ischemia. This is the Rutherford classification, class 4, 5, and 6. I've shown you some examples of these. These are the people that are at risk for losing their limbs. This is the Basel trial done a while ago in Britain, and it randomized balloon angioplasty to surgery. And the outcomes were not really different between the two groups. It was a lot less expensive to take care of patients with balloon angioplasty, and of course, in Britain, they're a single-payer system, the NHS, so they're very sensitive to cost. So this is something they embraced. The surgeons will tell you that if you look at patients who have more than a 2-year survival, that in this trial, there was some advantage to surgery. So surgery is not a no-no, it's not a never. But I do think that for most CLI patients, we're thinking about an endovascular first strategy. If we can do this with endovascular, that's fine. If you can't, then you move on to the next dose, next escalation. And this is a European trial that looked at what happens if you take critical limb ischemia patients and you let the physician who's seeing them, surgeon or cardiologist or radiologist or whomever, you let that physician pick. I want surgery, I want endovascular. Let them pick and see what the outcomes are. And so the primary outcome was amputation-free survival. And what you see here is that if you let doctors choose, not a randomized trial, just let me choose what you get, I pick right. I pick right for you most of the time, and you can see that there was equal benefit for surgery and endovascular therapy. And again, the key here is not to decide whether surgery or endovascular is better, but it's to let experienced physicians use their experience, use their skill to care for patients and apply what they do best for those patients. This is just an example of what balloon expandable stents look like in the tibial artery. And again, these are small arteries. These tend to be 3 millimeters or less. So they're very similar to coronary arteries, and they respond to treatment much the same as coronary arteries do. There's a lot of data now, several randomized trials and meta-analyses that demonstrated virtually every competitor, balloons, drug-coated balloons, bare metal stents, drug-eluting coronary, drug-eluting stents used below the knee win. So that's the best way to achieve patency. And again, here's a meta-analysis that looks at amputation reduction with drug-eluting stents. So hard clinical endpoints proven to be better with off-label coronary drug-eluting stents. The problem with the strategy is you need relatively discrete lesions. It really doesn't help you to have 3 feet of tibial artery to have to stent. There's not a good solution for that. So balloon angioplasty with bailout for spot stenting is probably the best you can do. And again, when we look at 5-year follow-up, the strategy of drug-eluting stents has sustainability. Infrapopliteal drug-coated balloons, not so good. Again, you'll see that blue dot is lines on the line of unity, which means that it's not better. There's no difference between the two groups. There's no superiority. And if we look at amputation, again, tough to prove that drug-coated balloons bring any benefit below the knee. So this is important to remember. Drug-coated balloons above the knee, good. Drug-coated balloons below the knee, not so good. So you just need to be on your toes and be thinking about what you're treating and how you're treating these patients. Tibial laser, no good. Tibial laser doesn't work. There's no advantage for running a laser up and down these small arteries and diffuse disease. No benefit. It's important that we continue to treat PAD as a team sport. This is one of the best places on the planet for a team to practice. Everywhere from the MA to the tech to the nurse to the PA to the nurse practitioner to the physician, everybody has a role. And if we all are on the same page and we're all enforcing and reinforcing the same principles for our patients, we make a lot more headway than a single voice out in the forest who you're not sure if they heard the tree fall. Unfortunately, I've talked to you about math a lot this morning. This is one final equation. You need to get this. Those of you who don't get this may not be here in a year or two. So this is the value equation. And you may have heard that we're going to be converting from volume to value. Volume means the more widgets you produce, the better you are. Unfortunately, the more widgets you produce, the more you cost. And if you don't produce value out of those widgets, then you end up being a source of cost. And then you end up being perhaps not a very viable entity in the healthcare marketplace. So we have to produce quality, which is outcomes, better outcomes, however you want to name them, walking distance, limbs healing, limbs staying attached, quality outcomes, service, patient engagement. I'm not so much into patient satisfaction, not because I'm not a people pleaser, but patients often want what's bad for them. I mean, why do you think they call them patients? So these are like children. I mean, you got to tell them to eat their veggies. I mean, these are folks who don't know what's best for them, but think that they have some opinion, some voice in the matter. Patient engagement is the art of making them think they've expressed a preference and then turning them around and saying, but you're right, doc, I want to do what you want to do. That's patient engagement. It takes skill, it takes some time, it takes some effort. You're not there to make people happy. Making people happy kills them. There are trials that show this. You don't want to make patients happy. You want to engage patients. You want them engaged in their care. That's what service means. And then, of course, cost is the cost it takes you to do this. Why is it important? I think everybody in the room knows that healthcare is the most expensive healthcare is in the United States, by far. Healthcare is very expensive in the United States. So what do we get for that? Well, we get screwed, right? So look at virtually anything that happens here and what you can get in other countries that you would go to have healthcare. Let me tell you, the quality of healthcare in Germany or France or England, these guys are good. Go to an international meeting sometime. They are really good. Go to Korea, go to Japan. These folks are top-notch practitioners, but they all do it less expensively than we do. And that's just not viable in a world where everybody is interrelated. And if you look at quality, the ones are good and the high numbers are bad. You can see that the NHS in Britain on the right side gets a whole bunch of ones. The United States, which is really expensive, has a whole bunch of 11s. How does that happen? And if we look at life expectancy, of course, for the amount of money we spend, we don't get the life expectancy that other countries do. And if you look at just overall healthcare ranking, we're at the very bottom of the pile. It's important that we don't take these numbers and say our doctors are bad or our nurses are bad. They're not bad. They're excellent. They make a lot of choices. But what we do that the other countries don't do is we have a lot of variation in how we provide care. Same problem, 6 doctors have 6 different ways to take care of it. Variation is the enemy of quality. I'm going to say that one more time. Variation is the enemy of quality. If you can agree by consensus in a group to do things the same way, your quality gets better because it becomes much more reproducible. Now, physicians will tell you that ruins my autonomy. And I say, well, you keep chanting that to yourself when you're in the unemployment line. I don't have a lot of patience for that crap. We need to take care of patients. We need to take care of them well. And we need to figure out how to reduce variation, or we're not going to make any headway here. What are we facing? What are the headwinds? The headwinds are as patients get older, they get more vascular disease. Guess what's happening in the U.S.? Guess what that red bar is? That's Medicare. That's a tsunami coming. They're going to, I'm it. I'm a baby boomer. And you have to take care of me. You're screwed. There's a lot of us out there. So unless we figure out how to do this a little better, there's no saving it. So you've heard about accountable care. I asked Dr. Khan yesterday, you have an accountable care organization here with the hospital. This is value versus volume. This is quality and safety. Reducing variation, patient-centeredness, patient engagement, and outcomes reporting. You have to know how you're doing. You have to collect your data. It's not that the doctors are bad. We're not bad. We're great. But we have way too much variation. We have choices to make. And you can see on the left, there's a ton of operations that we don't do anymore. At one time, these were standard of care things. They change. They're different now. It hurts when it's us. We're happy to have the orthopedic guys do something differently. But when it comes home to the cardiologist, we don't like that. But we have to understand that change will happen. We can embrace it, we can do nothing, and we can resist it. And I can tell you the last two, they're not compatible with a long professional life. So we aren't doing badly. This is 10 years of data looking at reducing mortality for critical limb ischemia. This is what's happened to the endovascular rate. This is why we're now embracing endovascular first. The surgical rate has dropped, not to zero because there are patients who need surgery. We just need to be able to tell which of those, how to sort those patients. The amputation rates are dropping. That's a great outcome, and that's something to be very proud of. And if we look at admission rates, you can see at the end they're going up. And that's because many of us are recognizing vascular disease as we haven't before. And so, again, the baby boomers are coming, more PAD, volumes are going up. We need to buckle in and get ready for this. It's going to be a real challenge. This is the problem. This is variation in revascularization rates across the country. People do it different. People do it a lot differently depending on the region. It's not about being better or worse. It's about not getting together and deciding how we want to do this. I will promote the BEST CLI trial, which is currently ongoing, which is a modern randomized trial of the best treatment for patients with critical limb ischemia. It's randomizing patients to endovascular versus surgery. And again, we're enrolling right now, and this trial is going to help us sort out the benefit of patients to have homogeneous veins on their first approach versus an endovascular procedure. And so I encourage you to think about this when you see CLI patients. I would encourage you to open a site, apply to be a site. We're opening CLI sites all over the country. So this is something that would be, again, something that would help us a great deal. I'm going to close with this slide. I think we all kind of understand we're special. I have a lot of confidence in what's going to happen in cardiovascular disease going forward. We just need to present the data, right? People need to be aware. It's called change management. People need to have the energy to change. I think that energy is coming, and we need to feel it, see it, and do it. And there's nobody better prepared than cardiologists to do this. Thank you very much.